Is it the holy grail? You know, we've had monofocals doing monovision, we've got bifocals, we've got trifocals, twin set IOLs, pinhole IOLs. Now, is this the holy grail? Is something we will try and discuss. So there has been a missing link because I feel the presbyopia which the patient gets after cataract surgery is an iatrogenic presbyopia. I have given it to him. So I think it's my responsibility to try and correct it as much as possible and make patients' life much happier. So this image actually tells me you, because even I'm in this age group, but luckily, maybe because of my yoga, I don't need glasses, but yes, my wife who's younger than me needs glasses. So I can have a separate session on eye yoga for you people. So this is how the lens looks like. It's absolutely smooth, no diffractive designs, no bumps, no droplets, no beam-shaped curves. It's an absolutely smooth lens. You cannot even pick it up on a slit lamp what the lens is doing in the eye. So I'll be just touching these few points: the pupil size, the corneal surface disorders, and the aberrations of the lens. There are main 3 or 4 categories here where we are using these presbyopic lenses or these EDOF lenses, the multifocal IOLs, as all of us know, the enhanced monofocals, the extended depth of monofocals, pinhole IOLs and symphonies, and of course the accommodative lens. And I've had a trial of all these lenses, right from crystal lens. When it came many years ago, I used a lot of crystal lens, but then I burned my hands and I moved away. So different technologies using different principles. In diffraction, as Dr. Pakyat said, you distribute the light into different focal points. In refraction, you use refractive powers of the lens surface, and pinhole, as we all know, does give you an amazing depth. What these lenses do for us is, while they give you a very good distance vision, the compromise on light, the contrast, the halos or the photic phenomenon with large pupil sizes at night is negligible. And I'm very happy to say I've done more than 7,000 of these lenses in the last 2 years. And I have a follow-up nearly 2 years now, and patients are doing very well. Few points which I will discuss as we move along would be that these lenses work on stretching the focal point. So it's a continuous zone of focus, unlike the diffractive lenses where you have focal points. So you have a zone of blur, you have a zone of clarity. You have a zone of blur and zone of clarity. So this zone of blur will give you loss of light, halos, and dysphotopsias. What happens in the EDOF is you have an elongated zone which goes from the intermediate to distance. So the loss of light is less. The area under the modular transfer function curve, which we will see as we move along in the forthcoming slides, is higher. So less lost light. So, is it working? No. So if you see here, in the EDOF zone, there's a larger zone of light distribution even in the intermediate zone, and it's a continuous light. So there are no zones of blurs. So to make you understand what is the limiting factor in an EDOF, plain EDOF, that you cannot induce more aberration. Why so? So we all know the positive spherical aberration lenses throw the peripheral light rays a bit in front of the focal point, and the negative lenses throw it behind. So let us say we start playing with this spherical aberration so that we can tabulate a zone which is continuous here. So from FM to FP, if you join these, and you can have a continuous zone. Yes, this is beautiful, but why can't you have a near add of 3.5 or 4 in an EDOF technology? What will happen? This will happen. The moment you start increasing the aberration, the peripheral light rays will cause a problem. So there is always a limit to the distance which you can work with these lenses. So the distance probably would be a near add of 2.5 max, but the moment you would try to go beyond that on a single technology, without using a diffractive loaded onto the aberrated surface, you will have trouble. So this is probably what we'll see if we really try to push the depth of focus. So I tried taking a photograph of the operation theater using a fisheye lens. So how do you define an EDOF lens? An EDOF lens will work best between 1.5 to 2 diopters of near eye, which will be very good, especially if you have patients who are tall, and most of the people here in this part of the world are tall. They probably will not need any glasses for near. Now this is a trick which I tell my doctors. If you have a very short patient, we go the blended monovision. And if you have a very tall patient, we just do emetropia both eyes with a magnification lens. And patient is super thrilled because of the arm length. Now if I try to read my mobile phone, I'm tall and 6'2", perfect. So if this is the kind of patient you have, plain emetropia both eyes. If you have a little shorter patient, do a blended monovision. 0.5 up. So this is a trick. I'll just skip this slides. Now we'll be talking more about this is how a patient would see in an EDOF lens. So the first one is even till near at 1.5, the ability to read objects is very, very distinct. Whereas in a monofocal, it will start disappearing. So this is so confusing. I just don't want you to go through this chart. Now everybody is jumping on the bandwagon of EDOF technology. Hybrid technology, diaphragms, droplet, beam size, pinhole. There are lenses galore, and I've used all of these lenses. I've just been using the Femtis lens of late. I find it very, very interesting concept, but you need to use the femto machine for that. So I just jumped across. The Symphony and Panoptics will probably have issues of the same issues which another diffractive lens would have. Vivity, I've used a lot of Vivity lenses, but if I have a preference, I would prefer a magnificent over Vivity any day eyes closed, because I feel the optical quality is much, much better. Now this is interesting. In a monofocal lens, you have one single wave, most of the energy focusing at the distance point. In a bifocal, you have two heights of light distribution. In a trifocal, you have three. But in an EDOF lens of this technology, you will have a larger area under the curve, which means very, very good light transmission. Now this chart is very interesting. In the central part of the lens, nearly 2 millimeter, you have an increased spherical power. So if you do an autorefractometry of a patient or magnification, you might see the patient is minus 1.25, but the patient is still 20/20, and he's still able to do N9 for near. That is the pupil size. As the pupil goes smaller, the exposed area of the lens is more for the near vision. And if you see 0.9 millimeter of the center part of the pupil, you have the real power of 21 diopters. All above is giving you the near depth. This is the area again under the curve, which increases more intermediate vision as compared to the monofocal. Now I'll be just sharing 7,000 patients data, but now first requisite is the patient has to be very, very clear that he wants good near vision or is very happy with intermediate vision. And most of us would agree that they want okay intermediate vision, but they don't want any dysphotopsia. Most were okay to have an intermediate vision. Nano monovision, we were correcting bumping up to the first myopic emetropia on the eye master. So if it is anything less than 0.5, I go for that in the non-dominant eye. Anything more than 0.5, I don't go. Only very, very minimal patients agreed for going in for a diffractive lens because they needed near vision. So this lens is very, very forgiving, no glares, no halos, no light loss, excellent night vision. Now these are the factors which will actually help you to decide. First is have a clear corneal surface, good formula, pupil size. Yes, it is very, very important. Now, this lens is sensitive to your rexus size. If you have a very large rexus size, an ELP might change. You may land up with more myopia than normal. So have a decent coverage of rexus size of 5 to max 5.5 if you're planning this lens, and you cannot go wrong. If you have a slightly larger rexus, if you have an over rexus accidentally, then place the haptics in the lens of maximum linear size of the capsule rexus, otherwise you may land up in trouble. The reporting of glares and halos in my study was highest with your lenses of diffractive and bifocal, less EDOF, Symphony, Panoptics, and magnification lenses were the best. So we did this study of 450 patients. 68% patients did not require any glasses. It's a combination of blended and both emetropia. So maximum patients were hitting a target of near 70%, not requiring any glasses at all. So this is amazing. That's the reason I've been able to ramp up so many numbers. So these are probably the break factors or the breaking points which you'll be looking at. So cutoff points, a very large pupil or a very small pupil. a very high keratometry more than 45 diopters, a very flat keratometry less than 40 diopters. These things, if you just exclude and no surface disorders, you will be very happy, and I can assure you your patients would want to come back for more. And this is a small video. I think if it runs, can we run this video? This is a video. Yeah. So you see the surface is absolutely smooth. I'll skip the video, but what I wanted to show was the surface of the lens is so clear, it's amazing. And